Hello, good afternoon, sir.
Good afternoon.
Hi, sir. How are you doing, sir?
Fine, fine. How are you?
Doing well, sir. Can I test my share the screen on?
Yeah, yeah.
It is saying host disabled participant screen sharing.
No worry. Yeah, now you try.
Okay, sir. Is my screen visible, sir?
Yeah, yeah, visible.
Okay, sir.
So how long you worked at Teams, Delhi?
I was for 1 year, sir.
1 year.
Immediately after my MS, I was there for 1 year. 2015, I think around July, August to July 2016.
So KIMS is Krishna Institute of Medical Science?
Yes, sir. The same hospital. I'm in a branch of Kondapur branch. We have 4 branches of KIMS in Hyderabad. So Gachibowli and Kondapur are close by. So I go to both branches every day. I operate and see OPD in both hospitals.
At SGPA, there used to be a professor who used to do robotic transoral thyroid.
Yes, sir. Yes, sir.
What is it?
Professor Gyanchand and Professor Amit Agarwal.
Yeah, Amit Agarwal. I think I had met him in a conference. So you are also doing robotic surgery?
We don't have robo here, sir. Actually, I'm doing a fellowship in robotic surgery. It's called FARIS, Fellow Association of Robotic and Innovative Surgeons. So I can do endoscopic transoral thyroidectomy, but we don't have robo yet, and I have not done robotic surgery yet, sir.
So you're able to do endoscopically, I mean, using laparoscopic instrument.
Yes, sir. Yes, endoscopic transoral.
How many instruments you need? 3.
Yes, sir. 3 ports. One central port will be for the camera, and 2 5mm on each side for the dissection and resection part. It's actually reverse. We everything is reversed from top bottom. I mean, the view is reversed. So it's called transvestibular approach. There are many approaches for transoral thyroidectomy. The one that I have been trained is transvestibular. Toetwa it is called as. So we take incision in the lower lip, away from the frenulum, close to the lip crease actually, and then after we do hydrodissection, then insert the first port. Then we put lateral ports, avoiding injury to the mental nerve, and we first open the midline and then do isthmusectomy, and from there we open it like a book, and then from there we do the thyroidectomy. Normally the approach is lateral to medial. In transoral, we do from medial to lateral.
Yeah, I remember. Yes. So what we do, we will wait till 12 o'clock. Then you can start by 12 to 12 o'clock, 2 minutes, then you can start. Right?
Sure, sir.
So you are the only person in Krishna Institute in endocrine surgery department?
Yes, sir. I'm the only endocrine surgeon in Hyderabad in KIMS Hospital. We have 4 more endocrine surgeons, one in Apollo, one in I think she's in Virinchi Hospital. One is in Care Hospital. Other is freelancing. So we are totally 5 of us. From SGPJ, I'm the only one. The other doctor is from CMC Vellore. Dr. From Virinchi. She's also quite senior to me from SGPGI.
There's one of our alumni who was senior to you. You may be
Ranjit.
knowing Ranjit Sukma. I don't know
Yes, sir.
whether
Ranjit is in Kerala, sir.
you will join or I don't. Maybe busy. May
Sir
join
is in
also.
Kerala. Yeah.
So you know him, no?
Yes, sir. I know. We are a very small community, so we know almost everyone. I think Dr. Banu Prakash is enjoying his coffee. Do we have robo, sir, in JIPMER? Not yet, no, sir. We have
Yeah, we have been doing since
in surgical touch.
2019.
Okay.
2019 we are doing. In between, when there was, because of COVID, it was not progressing, but now it is progressing a lot. We are able to do a lot of abdominal surgery using robot.
Yes, sir.
We have done even nipples also.
Oh, wow. Wonderful.
Esophagus,
Well,
colon.
in JIPMER, actually, my least exposure was in actually thyroid and parathyroid, because in unit 1 and 2, we didn't do so many thyroids and parathyroids. But when I went to AIMS, I was with Dr. Sunil Chumbar. So that is where we would do almost 2 to 3 parathyroids every week. We would get big parathyroid adenomas in North India. So that is where my interest shifted to endocrine surgery.
Yeah, AIMS you get a lot of, because
Yes, sir. Yeah.
lot of reference from the neighboring states,
Neighboring
especially
state.
from Bihar and other.
Yes, sir. So with Professor Nishima sir's guidance only, I've taken up this branch, breast and endocrine surgery.
Dr. Seen was also in the same unit.
Sir, Professor Sinu was in unit 3, sir, at that time. He used to do breast and thoracic surgery and renal transplant.
He comes here as examiner.
Yes, sir.
Seen, Dr. Seen.
So in our unit, Professor Sunil Chumbar and Dr. Sandeep Agarwal, both of them used to be there. Dr. Sandeep Agarwal was a bariatric and renal transplant surgeon. Professor Sunil Chumbar was very well known for endocrine surgery and splenectomies for ITP. And he was a great teacher.
Who are the faculty involved in MCH minimally invasive surgery teams?
Minimally invasive surgery, I think Sinu sir, Rajendra Prasad sir, RP sir, Sunil Chumbar sir. Actually, they have rotation, sir, in MCH, minimally invasive surgery. So, but I think they mostly have exposure in abdomen and thorax also. So, one of the MCH candidate from AIMS is purely practicing thoracic surgery, VATS and robotic here in Hyderabad.
Or Rajendra Prasad does a lot of thoracoscopic surgery.
Yes, sir.
Earlier, Dr. Aravind Kumar used to do. Now he is at Medal.
Okay. We have now a DNB and MCH thoracic surgery also. So, cardiac surgery and thoracic surgery have been separated. So in our center, we have a thoracic surgeon who did DNB from Narayana Hridayalaya, Bangalore. So there's so much subdivision in surgical branches and a lot of overlap also. So there is a lot of fight for domain. Who should do what?
Usually, the number of participants are around 30 only. So no need to worry. So you can start at 12 to.
Sure, sir. I'll mostly talk keeping the residents in view.
Yeah.
So yes.
Yeah, majority are our residents.
Yes, sir. Dr. Harish Gautam is also with us in KIMS Surgical Gastro. He was 2 years junior to us to be in JIPMER, sir.
The MCH from where?
MCH from Srinagar, I think.
Okay, let me introduce you. After that, you can start. I think. So, Dr.
Yes.
Ramya Oliveira is currently a consultant endocrine and breast surgeon at KIMS Hospital, Hyderabad. She did her MS from our institute, JIPMER. After that, she went to AIMS for doing senior residency, and where she developed interest in breast and endocrine surgery. From there, she moved to SCPGA for doing her MCH in endocrine surgery, following which she has joined KIMS Hospital, Hyderabad, and she has been practicing breast and endocrine surgery. Today, she is talking on an important topic which is useful for our postgraduate, and the topic is surgical management of parathyroid disease and focused parathyroidectomy. So, many of you may be having difficulty in understanding this topic. She will make these things simple for you. So, over to you, Dr.
Thank you, sir. At the outset, I really thank you for giving me this opportunity. And I hope that the postgraduates will be benefited with this talk. At least if I'm able to make you understand that there is a complex understanding that is needed to take up these patients for surgery, then yeah, I'll begin my talk. So we all know that normal adult human parathyroid is very, very small. It's about 5 millimeter in size, and it weighs up to 40 milligrams. So usually there are 4 of them in most adults, but they could be less in number, they could be more in number. And rarely in a state described as parathyroidomatosis, small clusters of glandular cells are present in the tissues around the parathyroids or in the tracts of their development. And these clusters, what is the importance of these clusters or the cells that can be present is that in generalized disease of parathyroids, like for example, parathyroid hyperplasia, the outcome of the surgery depends upon how many glands that you're able to identify and resect. So we have seen that in diseased parathyroids, numbers could be 6, 8, 10 or more. So 85 to 95, 93% of the individuals tend to have 4 parathyroids, but 3 could be seen in 2 to 3%, and supernumerary can be seen about 5 to 13%. And ectopic locations can also be seen in about 8 to 9%. I'll actually come to the details of this in a while. So why are we surgeons talking about these parathyroids? There are certain surgically curable or manageable parathyroid diseases, which is mostly hyperparathyroidism. So hypoparathyroidism doesn't have surgical role, but the importance is, of course, after total thyroidectomy, if we have not been careful in preserving parathyroids, patient can land up in permanent hypoparathyroidism. Mostly, though, temporary hypoparathyroidism with hypocalcemia is common. But if we have not been careful, it could result in permanent changes. But surgically treatable conditions of parathyroids are mostly hyper functional conditions. So the most common of them is a primary hyperparathyroidism, where the parathyroid gland is secreting more PTH thereby causing hypocalcemia. And the other conditions are secondary hyperparathyroidism due to a chronic kidney disease. But there are specific indications for surgery in this condition, which I'll be just briefly touching upon in the later part of my slides. And there is something called as tertiary hyperparathyroidism, which is a sequel in the course of secondary HPT. And there's a rare condition called as neonatal severe hyperparathyroidism, where the surgery can be helpful. But by far, PHPT, the primary hyperparathyroidism, is the most common condition that we surgeons encounter. And here, we have to remember that the biochemical diagnosis is the most important. So, a PTH concentration that is frankly elevated or within a normal range, but inappropriately normal for a patient of hypercalcemia. So we know that there is a feedback mechanism where PTH, vitamin D, and other factors maintain the calcium levels within normal limits in a very narrow range of optimal range in the blood. And if there is increase in calcium, the PTH should go down, right? So even if the PTH is normal for a high elevated calcium, still it is called as a primary hyperparathyroidism. So there are other causes for increased PTH like vitamin D deficiency, but there we don't see calcium to be elevated. There are other causes for hypercalcemia like sarcoidosis or hypervitaminosis D. Their PTH won't be elevated. So for a given calcium, for an inappropriately normal PTH or elevated PTH with hypercalcemia are the biochemical criteria for diagnosis of primary hyperparathyroidism. For example, what I'm trying to say here is, if ultrasound scan neck is done for some other reason, say a carotid Doppler is done and somebody notices that there is a lesion looking like a parathyroid adenoma, we don't call this as a primary hyperparathyroidism unless proven with a biochemical support. So the basic tenet for this is a biochemical diagnosis. So hyperfunctional parathyroid glands release parathormone excess in an uncontrolled manner out of this feedback loop. And most commonly, there is a single gland that is doing this. So usually it is a parathyroid adenoma, or rarely it is a carcinoma. But 10 to 15% of the cases, multiple glands can be involved, either in the form of a sporadic disease or associated familial endocrinopathy. And single gland typically presents in 6th decade with uniglandular involvement, but there are so many exceptions to this in my own experience. Elderly ladies, or the typical is the elderly lady who's supposed to come with this diagnosis of PHPT. But in my experience in AIMS as well as in SGPJ, and of course in my practice, we see that so many young women come with single gland disease as well. But the threshold to work up for multi-gland disease and keep them under close follow-up should be more for women who come with, or men who come with PHPT in their younger age groups. So for biochemical diagnosis, increased calcium, increased PTH, low or normal phosphorus, and please also check serum albumin, because we have to use corrected calcium, and please rule out renal disease, check for serum creatinine, and rule out secondary causes, check vitamin D, because sometimes patients with PHPT may have normal calcium because they're vitamin D deficient. So if you correct their vitamin D, the hypercalcemia is unmasked. So the other thing that we have to check is a 24-hour urinary calcium creatinine ratio, because there's a disease called as familial hypocalciuric hypercalcemia, where there is a mutation in the calcium sensing receptor that causes less calcium to be excreted in the urine, and the same mechanism, CASR related increased PTH, as well as because of low excretion of calcium, there is hypocalcemia. But these patients have the ratio less than 0.01 in 24-hour urinary sample, whereas more than 0.04 in PHPT. So that is very important, because in FHH, you don't find any enlarged parathyroids. These parathyroids are normal and it's not a surgical disease. So if we don't pay attention to this, we may unnecessarily land up operating these patients, but their hypercalcemia and hyperparathyroidism are going to persist. So that is one thing that we have to remember. And the common imaging that we do are two types of imaging. One is anatomical imaging in the form of ultrasound sonography, a high resolution ultrasound scan. And sometimes we use a 4-dimensional CT these days. And what is a 4-dimensional CT? The fourth dimension is time. So it's ultra fast in very, very early arterial phase, when the contrast goes into the parathyroid glands. So we pick them up, and then there is a washout in the delayed phase. So that is called as a 4D CT. It's just a software that is needed to be installed for this, and it is very helpful in certain cases. So the other type of imaging that we use in PHPT is a functional imaging. So it mostly in the form of a sesame parathyroid scintigraphy. Nowadays we have a SPECT CT add-on onto it to get good spatial resolution. And functional imaging, other things that we have now are carbon 18 methionine, and other type of scans that also we have. And functional imaging becomes especially important for ectopic parathyroids. So for example, if we just do ultrasound and we have seen a gland, and suppose we have taken up these patients for surgery, if there is another ectopic in the mediastinum, then we are going to miss it. Suppose we have a biochemical diagnosis of PHPT and we just do anatomical imaging of the neck, we may again miss mediastinal or ectopic parathyroid adenoma. So anatomical as well as functional have to be performed in both have to be performed in patients with PHPT. And if we have a concordant imaging, so I will talk about it in a bit. So in ultrasound scan, it is important that surgeons also get trained in identifying a parathyroid, because it helps us in being more confident that it is not a lymph node, because sometimes enlarged lymph nodes could look like parathyroidenoma. Sometimes a detached thyroid nodule can look like one. And so a surgeon has to be very well versed with performing ultrasound scans of these patients. And on sonography, these look like a homogeneous, usually hypoechoic, but I have seen patients who have cystic changes, hyperechoic, solid cystic, all sorts of things. And then we see that there is peripheral vascularity with one vessel entering into the parathyroid. So that is the sign that it is a parathyroid, where we don't see this in lymph node. In lymph node, there is hilar supply, unlike the parathyroid adenoma. So this was a very important case, where this was a case of MEN1 actually. So the radiologist had missed this small parathyroid. This patient had undergone surgeries earlier in Bangalore, but she had come with recurrence. So now we could clearly see on MIBI scan only one parathyroid abnormal gland. But when I performed the scan, I identified this parathyroid, and I'll show you in the images later that this was also indeed a enlarged parathyroid gland, and this patient is now cured of PHPT. So it's what I'm trying to say here is that we endocrine surgeons, as surgeons, we have to be very well versed, and we need to look for all possibilities in a particular patient. Otherwise, we may end up with a failed surgery. So as I was saying, 4D CT scans, the parathyroids take here we take advantage of the rapid contrast uptake and washout that is the characteristic of parathyroid glands for precise anatomical localization. So here, as we can see, it's in posterior location to the thyroid. So sesame B molecule is taken up by the mitochondria in the thyroid as well as parathyroid tissue. So in interpreting these sesame B scans, one has to be very careful. So we have to perform delayed scans, and then we can do subtraction scans also. So sometimes when thyroid is a lot of overlap is there, we can do subtraction scans to delete the image of, to subtract the image of thyroid, and then look at only parathyroids. So early, delayed, and with oblique and planar views, with or without SPECT CT, can be very helpful. But of course, SPECT CT is going to give us orientation on the plane, on the anterior to posterior plane of the parathyroid. So the images that we are seeing here, in the early image, we can see that the thyroid is also showing uptake, and in the delayed phase, 90 minutes maybe static images, here we can see that there is a left inferior parathyroid adenoma, and these are planar, these are the scintigraphies. So this is the SPECT CT. Here we can see that the thyroid is showing uptake, and here just posterior to the thyroid, we are able to see that one more lesion is showing uptake. Okay. So surgical approach in single gland disease. So, actually for the parathyroid surgery can range from a very, very simple, straightforward surgery where you open, you find the gland, especially if it is an inferior one, open, just mobilize the muscles, then just rotate the thyroid a little bit, you can find the gland and it can get over in 10 minutes. And sometimes you search for the gland for hours together. still you may not find. So it can be so complex. So one has to be really prepared for troubleshooting of this sort. So how to approach for a patient with single gland disease? First of all, you have to be sure it is a single gland disease. What helps us in determining whether it is single gland or not? The age, the way the PHPT presents. If a patient is having a just mildly elevated calcium with mildly elevated PTH, with family history of renal stones, you have to suspect familial disease and multi-gland disease. And especially maybe negative scans, maybe negative PHPTs could have multi-gland disease, even though it could be sporadic also. But a very clear-cut big adenoma, single adenoma seen on ultrasound as well as maybe can reassure you that it could be a single gland disease. So here, these single gland disease adenomas are developed because of mutations in many kinds of genes, but most commonly calcium sensing receptor MEN1 gene sporadically. Okay, I'm talking about somatic mutations here. So there is a difference in somatic as well as the germline mutations. So germline MEN1 mutation, we know that it is MEN1 syndrome, menin gene. But even sporadic adenomas can have mutations in MEN1 gene, and CCND1 PRAD gene, CDK1 mutations can be seen in sporadic parathyroid adenomas. And if both ultrasound or 4D CT along with functional imaging show that there is only one gland, and then you are confident that this patient is having a profile of single gland disease, then we can try this patient, we can post this patient for focused parathyroidectomy. So what is focused parathyroidectomy? Here, we are going to explore right on the gland that we have identified, open, just remove the gland and close. So we are not going to look at other parathyroids. So there is no unilateral exploration. There's no looking for other gland on the same side. So that is called as focused parathyroidectomy. When there is a discordance, or when you have in your mind not sure it could be single gland disease because of the profile, then you do something called as a bilateral neck exploration. So look at the surgery's name. It's like exploratory laparotomy. So you're exploring the abdomen like that. Here you're going to explore the neck. But fortunately, in abdomen, the structures are big. Here in the neck, the parathyroid could be minute. They could be very small. So you have to be really have the eye for the parathyroids, and you will go on an expedition looking for this abnormal parathyroid, right? So in discordant, you can choose to perform either unilateral or a bilateral neck exploration. And in focused as well as in bilateral neck exploration, we have some adjuncts who are surgeons' friends. For example, frozen section. So sometimes patients, women tend to have Hashimoto's thyroiditis and some other inflammatory conditions which can enlarge the lymph nodes. So there could be multiple lymph nodes within the neck, and when you open, especially when the parathyroid is very small, you may get confused which one of this is parathyroid. So, but experienced surgeon is usually able to differentiate parathyroid from the lymph node. But sometimes you need to have proof because your patient has spent some money and you can't afford to misjudge. So for your reassurance, you can use a frozen section analysis. And frozen is also useful in multi-gland disease where if when you open by chance, if you have seen that the other parathyroid is also abnormal, then you can send it for frozen and see if that is looking normal or is looking hyperplastic. In pathology, the pathologist may not be able to tell you whether it is adenoma or hyperplasia. They cannot differentiate, but they can tell you whether it is a normal parathyroid gland, abnormal parathyroid gland, or it is not a parathyroid gland. So that is how we have to use frozen section. And we all know that there is a protocol of intraoperative PTH. There are so many criteria, and the most common that we use is a modified Miami criteria, where we do PTH before induction, after induction, and 5, 10, 15 minutes post surgery. And if the value of PTH at 10 minutes is more than 50% drop is there compared to the highest between the pre-induction and pre-excision, then we call the patient as cured and conclude the surgery. But there are so many other criteria. There are Lucknowi criteria, there are Rome criteria. So I have the most experience with modified Miami criteria. And even if intraoperative PTH is not available, we can manage with good preoperative preparation and doing good imaging. So intraoperative nerve monitoring for RLN is an option, but we can use it selectively for, especially for parathyroid carcinomas. Sometimes there could be difficulty, especially in descended superior glands. So so a surgeon has to understand that recurrent laryngeal nerves and parathyroids are very intimate relationship. So inferior gland is anterior, superficial. So when we go from anterior to posterior, superficial to deep while operating, so we first encounter the inferior parathyroid, then the RLN, and then of course superior gland is going to be posteromedial to the RLN. These are normal anatomical locations, but if we have operated thyroids, we have seen that the position is not constant and there can be a lot of variations. But in general, the plane of the inferior parathyroid is anterior to the RLN. Sometimes what happens, an abnormal superior gland, because of its weight, can track down, right? So then your imaging and your functional imaging and ultrasound are going to tell you that this is an inferior gland. So then you are very you think that if you are staying close to the gland, you may not encounter the RLN. But in this case, your parathyroid gland is posterior to the RLN. Though it is inferior, it is posterior to the RLN. So in that case, you have to be really careful. There are some cases where a nerve has been injured. Sometimes because of this descended superior nerve is pushed so medially, it almost looks like a artery that is entering along the inferior part of the gland. I've seen such cases. So if you're not careful, then these patients can have RLN trauma. So it's important to keep this in mind, right? So in those cases where you have carcinoma, intraoperative nerve monitoring can be very useful, but routinely it's not warranted according to me. So there are certain steps for focused parathyroidectomy. So the first prerequisite is having concordant imaging. That is, it should be a single gland disease, and a small incision is given. But after localizing the adenoma on the intraoperative, so once we position the patient on the OT table, after before painting and draping, we do the scan ourselves and mark where the parathyroid adenoma is, and we give incision right on that area. No need to be central like the transverse incision of the thyroid. So because it's going to be a small incision, you can place it right on the abnormal gland. Then go in the subplatysmal space. You can have two approaches now. So if it is close to the midline, dissect from the midline and then deliver the gland. Or if it is a little bit lateral, then you can go from lateral approach. So go lateral to the strap muscles, and from there you can approach the gland. So expose the parathyroid bearing area. And from the ultrasound, you can also actually get a guess of what could be the depth of the gland. Sometimes it could be inferior, but it could be more deep. So in those cases, you can measure it from the skin and understand how deep you have to go to look for the gland. So then dissect close to the adenoma, no holding of the parathyroid with no holding on to the capsule of parathyroid. So you have to hold the surrounding tissue to the parathyroid adenoma. The capsule should be absolutely intact, because we know that the parathyroid cells are capable of implanting themselves wherever they get dislodged. So one has to be very careful. And I tend to hold the surrounding fat and then use bipolar and just monopolar and try to push tissues down. And there could be one or more vessel that needs to be ligated. But I mean, off late, I use sutures very less. In thyroid and parathyroid surgeries, we do sutureless surgeries. So bipolar is good enough. And the important thing is to not injure the nerve as well as the capsule of the parathyroid adenoma. And if you think it's needed, you can use frozen section and intraoperative PTH. So this is how a parathyroid adenoma can look like. So this is another adenoma. See this, it could be as small as 1 centimeter or 3 centimeters. Here, this patient had a these lymph nodes were identified, and some of them I had sent for frozen section. They said there is a metastatic deposit from papillary thyroid carcinoma. So then we did right hemithyroidectomy along with parathyroidectomy in this case. And this patient also has a FLUS, follicular lesion of undetermined significance, that is the 3 category nodule on the right side. So this patient and with multiple small nodules on the left. So total thyroidectomy and parathyroidectomy in this case. So this is one of the cases of my senior where he did VATS parathyroidectomy because the adenoma was in the aortopulmonary window. So this is how the MEB scan is going to be helpful. So if we just do a neck imaging, we may miss all these things. So we should not get away with functional imaging for the patients of PHPT. So I have also seen intra lobar adenomas. So within the lung. So when I was in SGPJ, we had a patient who had adenoma within the lung. So that was also done through VATS with the help of our cardiothoracic surgeons. So now that is a simple thing. When we thought that it is a PHPT, there was an adenoma that was known, and we found it where we thought we find it. But sometimes things are not so simple. Then we have to know how to troubleshoot in this focused parathyroidectomy. So the first thing is, please look at the deeper planes in the same place that you earlier identified it. So as I was saying, the superior gland sometimes can track down and appear like inferior, especially if you have been very reluctant and not performed the scan yourself and not measure the depth. Then, because inferior glands are so simple, so whenever there's an inferior gland, we just go in and we are very confident. We expect the surgery to get over in everything together in 45 minutes. But sometimes you may not find the inferior gland. So then you have to just go deeper in the same location, go posterior, be careful with the nerve, and then if you find, well and good. Otherwise, then identify the RLN and explore the entire ipsilateral side. So maybe there could be a change in position, or the position that you do scan and the position that you are doing exploring intraoperatively could be slightly different. So then go explore the same side. So exploring same side means, it's sometimes challenging, especially if the gland is very small, because some women tend to have a lot of fat in the neck and a lot of lymph nodes. So it could be a messy surgery then. So you have to be really patient. And intraop adjuncts like ICG can be helpful to see if there is a ICG avid big lesion, which is probably a parathyroid adenoma, using infrared. Sometimes if you have done a MEB scan just in the morning, so you can use a gamma probe intraoperatively and try to localize this parathyroid adenoma. But this facility is not available in most centers. We also don't have it in KIMS hospitals in our branch. So other thing that can be helpful is an intraop ultrasound. But because the field is full of it's open and the planes, there's a lot of air between the probe and your adenoma, so you can use saline and betadine to get the interface between your probe and the tissues. But ultrasound, in my experience, intraoperatively is not helpful. Preoperatively, of course, it's the boon, and you having experience with it is going to help. If none of it is helping, please convert it to bilateral exploration, where you open the neck like you open for thyroid. And here comes the knowledge of embryology and anatomy of the parathyroid. So the simple things that we all know, that the thyroid parathyroid glands develop from the pharyngeal pouches, and that the superior develop from the fourth and the inferior develop from the third. Here is the importance of all these things. So please remember this, that the superior develops from the fourth and stays there, and inferior along with the thymus travels below, right? So with that, there is an area of dispersal for normal inferior parathyroid glands. So you expect inferior parathyroids to be normally present around these areas. What are those areas? That is inferior poles of thyroid lobe, thyrothymic ligament. Sometimes between the thyroid and the thymus, there is a ligamentous, some sort of a fibrous structure. So if when we are doing central compartment neck node dissection, we all must have noticed this. So there could be a parathyroid tissue in this tract, or it could even be in the superior pole of the thymus. That we of course don't classify it as a normal inferior parathyroid location, but it could be in the thyrothymic ligament. And upper cervical portion of the thymus is still possible in many times, and middle third of the posterior aspect of the thyroid. So it might be a little more proximal than you expect it, right? So the superior gland follow the thyroid migration, and which travel towards the lateral part of the main median thyroid rudiment. So posteromedial location close to the mid part of the thyroid is where we expect the superior parathyroid. But there could be congenital ectopias. that could be caused by either deficient migration or because of excessive migration of one or more than one glands. And there could also be development of accessory parathyroid fragments. So on the way to their travel, parathyroid tissues may be deposited along the track of their path migration. So in single gland disease, this is okay, but if it is in multi-gland disease, this is a hell, because then you really have to be careful in whatever looks like abnormal brownish tissue, you have to keep resecting it, right? So for superior parathyroid ectopias, if we talk about ectopias in superior parathyroid, because the area of disposal is limited, because the short course, rarely ectopic as far as superior glands are concerned. So, yeah. So if there is excessive migration of superior parathyroid, then there could be intrathyroidal location. So at the time of fusion, they get incorporated into the thyroid. But not all intrathyroidal are superior. There could be inferior glands that are also. So sometimes when, especially in MEB and scan, hello, am I audible, sir?
Yeah, audible. Sorry for the small interruption.
No problem, sir. Yeah, I understand.
Others.
Yes, sir, I understand. So, yeah, if we are not able to find the gland in the, but we are sure that an ultrasound and maybe showing the same gland, then the gland could be intrathyroidal. Most commonly, intrathyroidal is superior, but inferior can also be thyroidal, right? So that is because of excessive migration. If we have deficient migration, we can see that the parathyroid can be in the superior pole of thyroid lobe also. So this is another reason where if we are paying a lot of attention to thyroid surgeries when we are operating thyroidectomies, we nowadays we know that the both inferior superior pole have to be done onto the gland. So we no longer I no longer go and tie superior pole. So I take all the individual branches on the thyroid gland. So the subcapsular dissection also saves. This is important too in two aspects. Number one, in thyroid surgeries, there could be a superior parathyroid that needs to be saved near the superior pole. So here you have, if you are on the thyroid, then you can save this parathyroid along with its intact blood supply. In case of abnormal glands, if you are not able to find it in its usual location, then please also look for the superior pole of the thyroid where you can find this abnormal gland. So that is the importance of this. And it is not uncommon. We have encountered many glands that are close to superior pole. So when you, especially when you are rotating the thyroid and taking the lower outer aspect of the superior pole, you have to be careful to preserve the parathyroid supply, because if you're not wary, you can actually injure the blood supply in thyroidectomy, and then you see that the gland has lost its vascular supply. So other deficient migration locations could be behind the pharynx or esophagus. This is seen in about 1 to 4%. And sometimes it could be above the upper pole of the thyroid lobe. That's going to be a very difficult one. So what I'm trying to say here is all these locations have to be kept in mind, have to be explored if you're not able to find an abnormal gland in the location that you expect it to be. Because sometimes we encounter situations where we have clear-cut biochemical diagnosis of PHPT and we are not able to localize the gland intraoperatively. So that's why a famous physician, John Dopeman, has said the best localization technique for parathyroid is localize a parathyroid surgeon. So a one who has clear knowledge on biochemistry, clear knowledge on how to identify a parathyroid tissue when she or he sees one, and when knows how to explore where to explore without damaging the vital structures. Okay, so so this is juxta cricoidal location of superior gland, and this is behind the upper pole, and this is retropharyngeal or retroesophageal locations. This we have seen with many parathyroid adenomas, which are like this, retroesophageal. I'm not sure whatever factors that are causing abnormal migration are also responsible for adenomatous disease, but abnormal glands tend to be more ectopic than normal glands. So coming to the congenital ectopias of inferior parathyroid gland. So there could be undescended inferior parathyroid glands. Then it remains close to its origin, that is near the carotid sheath. So this, how do they know it is undescended? Because they have seen that there is a thymic tissue and parathymic tissue fat along with parathyroid in the superior aspect, in more proximally close to the carotid. So it's important to look at the carotid sheath as well. So often in our endocrine surgeons group, our colleagues keep posting. I have not seen one in carotid sheath, but they keep posting. They have found adenomas in carotid sheath, just medial to the carotid sheath. So incidence of this undescended hyperfunctional inferior parathyroid gland is seen in 7 to 8. So here, I hope all of you are appreciating that this is not a superior gland. This is actually undescended inferior gland, though the location is proximal. So that is how things are different. So due to excessive, that was because of lack of migration. Now due to excessive migration, congenital ectopias of inferior parathyroid could be in the thymus, because thymus extends from the lower aspect of the neck into the thorax, into the anterior mediastinum, at the posterior aspect of the thymic capsule, and below the innominate or innominate aortic arch. So I'm going to be telling in the coming slides further about this mediastinal location. So coming to the acquired ectopias of parathyroid tumors. These are all congenital. Now coming to acquired ectopias. So abnormal gland, because of its weight and under the influence of gravity, under the influence of the movements of the larynx and pharynx during swallowing, or because of the suction phenomenon of the negative intrathoracic pressure, can migrate, right? So this mechanism is more observed with superior parathyroids than inferior ones, right? Because they have, especially if superior parathyroids are in the retroesophageal location, they migrate into posterior superior mediastinum. The inferior glands migrate into anterior mediastinum. The superior ones go into posterior mediastinum. So the acquired ectopia of superior parathyroid can be, the tumor can pass behind the trunk of inferior thyroid artery and found at the level of inferior lobes of thyroid. This is very, very common. So just last week, I have operated a lady who had an inferior gland, who was actually thought to have an inferior gland in the, more superficial planes. But then when I was operating, I saw that there was another gland, inferior gland, that was normal. So basically, this was a descended superior gland in this location, that is at the level of inferior lobes of thyroid. So it may also descend posteriorly into the tracheoesophageal groove or into the para and retroesophageal locations. So if you think that the retroesophageal location is possible, then please sweep your finger behind the esophagus. You will then generally be able to feel for the adenoma. Actually, here tactile sensation is very helpful. One thing is ultrasound, of course. I think more than visual identification of the gland, what I think is mostly helpful is your preoperative ultrasound and intraoperative tactile feel. So that is how you're going to identify. Of course, when you open, you find the adenoma, and the adenoma could be of so many colors and so many sizes and shapes. Sometimes you think that this is looking like a abnormal thyroid nodule, but that actually is a parathyroid adenoma, because abnormal glands tend to have cystic areas, and sometimes there could be surrounding fibrosis. So endocrine glands, when they have, even when they have benign conditions, this we can see with parathyroid disease as well as pheochromocytoma, they can have peritumoral fibrosis. So that is one thing we have to also keep in mind. So the color, the visual identification is not so important, but you being sure that this is looking, the way it is separate from the thyroid and the way it is moving, and all these things could also be important. So what I'm trying to say here is, don't just rely on how it looks. So acquired ectopia for inferior gland. So the tumor descends along the anterior path, along the thyrothymic ligament, along with the thymus, into the anterior superior mediastinum. And rarely, of course, it can also go into posterior superior mediastinum to acquire a paraesophageal position. So, of course, when we are operating, for us, It doesn't matter whether it is superior or inferior, as long as we are identifying vital structures and preserving those. But in bilateral neck exploration, to be sure that you have completely removed, this becomes important. And when we are not able to find a gland, exploring all these areas is also important. Of course, I wouldn't convert a surgery into thoracic exploration just to find if there is any abnormal gland in the thorax. So that is a decision that you have to take after if you have any evidence to open the thorax. So coming to supernumerary parathyroid glands. So these develop from the parathyroid debris left arising from the fragmentation of the pharyngotracheal duct, so the during development. And I told you the statistics and the continuous growth stimulation, especially in hypoplastic diseases, in familial diseases, and in secondary causes. These could pose a real big problem. So these are located most often at the level of lower poles of thyroid lobes, in the thyrothymic region, in the thymus, within the carotid sheath, lateral to the jugular-carotid axis, in the middle mediastinum, at the level of epigynous, or intravagal. I mean, there have been cases where within the bundle of the vagus nerve, also people have found parathyroid adenomas. So that is how complex it can be. So here in single gland disease, I want to mention especially about HPTJT, that is hyperparathyroidism jaw tumor syndrome, where it is a heritable single gland disease. So this is a heritable but a single gland disease, and hypercalcemia in patients with this syndrome is due to a single gland abnormality, and it is seen in about 90% of the cases like that. Of course, in 10% it could be abnormal also, but there is a chance that there could be a malignancy in these patients. There's a 15 to 20% chance that this could be a carcinoma. So because of CDC73 mutation in these patients. So here, though we know that single gland disease, if you're suspecting this condition, especially very young patients, so these are in their early 20s or maybe late teens. So you have to do a bilateral exploration. And if you have any suspicion of carcinoma, please do en bloc resection. The first surgery is the best surgery for parathyroid carcinoma. Otherwise, they're going to have innumerable recurrences and patient will never be cured. So please do en bloc resection if you are suspecting a carcinoma, along with the ipsilateral thyroid lobe and the central compartment lymph node dissection, with careful attention to the capsule and recurrent laryngeal nerve, of course. So a multi-gland disease, a brief, from here on, I'll just move a little bit fast because I think I've covered most of the important aspects in my previous slides. So as I was saying, multi-gland disease could be sporadic or familial, and the heritable forms account for about 15% of the cases of PHPT, and clinically represent a heterogeneous group of disorders, genetically and clinically. So it could be MEN1, which is very, very common. I mean, I never thought that MEN1 is so common, but it is common, and it is seen in about, I think, about 5 to 10 in 1 lakh individuals, menin mutation. So the other thing is MEN type 4, where the gene is CDK1 that is mutated. We know that MEN2A also has primary hyperparathyroidism in about 30% of the individuals. So when we are suspecting familial, of course, genetic testing is going to help, but clinically we can suspect if the patient is also having prolactin and pancreatic tumors, or if the adenomas are big and the calcium levels are high, it could be mostly MEN1, right? But in MEN2, the disease is going to be milder. So the MTC, medullary thyroid carcinoma, is the most important disease in these patients. And the PHPT is going to be milder, just slightly elevated calcium, slightly elevated PTH. So there's something called as familial isolated hyperparathyroidism, where so it's a spectrum of disease due to incomplete expression of either MEN1, HPTJT, or FHH. These are generally due to activating GCM2 mutations, where the patient has familial occurrence of PHPT, but you're not able to find these genes, like the classical genes, MEN1, HPTJT, or CASI mutations. That could be because of FIHPT, which is GCM2. So surgical approach for these patients. So as we can see here, this patient, of course, is a lymph node. This is perithymic fat. These are the 3 glands. So I did 3 gland excision in these patients. So here, one has to decide whether you want to do a subtotal versus total with autotransplantation, because if the autotransplanted tissue doesn't survive, then patient will end up with aparathyroidism, which is worse than hyperparathyroidism. So one has to be really careful in deciding the extent of surgery. So apart from exploring all the areas that I was just talking about in the past slides, one has to also remove the transcervical part of transcervically, whatever is feasible to remove the thymus also, because it could have ectopic abnormal parathyroid tissue. So in MEN1, there is pancreatic tumors, parathyroid hyperplasia, and pituitary tumors. In MEN2, we know that there is MTC, PHPT, as well as pheochromocytomas. So this was the lady that I was talking about. This lady had undergone already 2 surgeries. She had undergone right inferior, left inferior surgeries in the past, but again, she came back with recurrence. Now she has an abnormal, so we had to do bilateral exploration for her. And this was an adenoma that was identified. And there was a thyroid nodule here, which was Bethesda 3 done at, our center FNAC was done from thyroid. And when we are doing here, one thing I want to add that if we are asking for FNAC from thyroid nodule, we have to be very, very careful that they don't puncture or poke the parathyroid tissue, because if they puncture the parathyroid, then the needle tract recurrence could be a possibility. So this was another suspicious nodule that was there in the thyroid, but I didn't want to take a chance. It was looking like it could be an intrathyroidal lesion, so I removed this also. And this is a left superior parathyroid, which was abnormal. So this is the thymus. So nowadays we have entities called as normocalcemic PHPT, where it's a variant of PHPT. Patients have normocalcemia, but they come to the attention because of low BMD for their age, and during which we have seen that PTH levels are high, and there is no hypercalcemia though. So diagnosis of normocalcemic should be done if the total calcium adjusted for albumin and ionized levels should be consistently normal in the presence of elevated PTH, after ruling out all the secondary causes for hyperparathyroidism, because these patients are symptomatic for the PHPT. So this is, there have been studies where they follow up these patients and then they see that eventually these patients are going to develop hypercalcemia. And so informed decision has to be taken by when to operate these patients, right? There's something called as asymptomatic PHPT, where everything fits into PHPT, calcium, hypercalcemia, hyperparathyroidism, but the patient is totally asymptomatic. So here there are few indications for surgery, like if the calcium is more than 1 milligram per deciliter, or if there is a high risk for fractures in the vertebra, and BMD score is less than minus 2.5 at lumbar spine, hip, and the age is less than 50, patient is young, less than 50 years, or if there is a kidney disease that is going to get affected. So needless to say, parathyroid PHPT hypercalcemia affects all organs of the body, including central nervous system, psychiatric complications, and the hypertension, heart. The PTH molecule itself is cardiotoxic through aldosterone. This is going to be cardiotoxic, and it causes GI symptoms. It causes bone weakness. It actually makes patient's life hell. So if you treat a patient of PHPT, I think it gives maximum satisfaction to the surgeon as well as to the patient. So immediately after surgery, patients start feeling better. So the gloom that they have is lifted off. So many patients describe this. So immediately after surgery, within a day or so, they start feeling better. So that gloom, sense of gloom is gone. So surgery can really help in these patients who are apparently asymptomatic but are having some subtle diseases which are gonna worsen if you just leave them alone, right? So, and coming to the management of parathyroid carcinoma, it is a highly recurrent disease, and on-block resection is very, very important, and surgery is the only option. And pre-op suspicion, if the tumor is very large, or if there are infiltrative borders on ultrasound, or if the PTH is very, very high and the calcium is very high. But in our country, without even if there are large adenomas, they tend to be benign only. This is probably true for foreign countries, but in our experience, we have seen so many big adenomas with high calcium, high PTH still turn out to be benign. So I think infiltrative borders and intraoperative, that whitish fibrotic tissue is what probably can indicate to you that it could be a malignant parathyroid tissue. So this is one of my case reports while I was in SGPJ. This patient underwent her first surgery in 1989. She had an FNAC from this, thinking it was a thyroid nodule. So after that, she had the FNAC was done elsewhere, and then she had so many recurrences. The first surgery was done elsewhere, and second onwards was done at SGPGI, and she's still surviving. She keeps getting recurrence, and so many surgeries have been done upon her. So it's not a good thing to experience this. So it's important to suspect and treat these patients at the first go. So a brief about secondary HPT. It could be because of CKD, but here in CKD, the calcium is going to be less, but PTH is going to be high. And there could be, there's vitamin deficiency because the kidney doesn't activate the vitamin D, and the phosphorus is going to be high. So, but there are very few indications for surgery for parathyroids in CKD. Number one is if you have done maximal medical treatment and the patient is having life-limiting bone disease or bone pains and muscle aches and PTH above 800. But this 800 we don't follow in India because typically the PTH is around 800,000. So here we say about 1500 and 1800, especially patient is having so many symptoms. And or if there are extra-osseous calcifications or calciphylaxis, a painful condition because of calcium uremic arteriolopathy. These are definite indications, or hypocalcemia in the presence of malignancy. So these are few indications where in CKD we explore the patients for parathyroid disease. And here extent of surgery is going to be bilateral exploration, subtotal versus total with autotransplantation. This has to be a decision that you need to clearly talk to the patient and decide. And because these patients have a very complex bone disease. So along with PHPT, they have bone renal osteodystrophy, mineral bone disease, high phosphorus, and other metal depositions, and also it's a very complex bone disease. And if you leave the patient with parathyroidism, they're going to have a hell of a life. So I think subtotal, which is 3.5, or along with total parathyroidectomy, do a very fine, a good autotransplantation. That you should be having maximum efforts from your side to make the parathyroid survive in the brachioradialis. So here I generally do maybe scan to rule out any mediastinal location of the gland to have success in surgery. So tertiary is when the patients with end-stage kidney disease start developing hypercalcemia. So just now we have seen that CKD patients have hypocalcemia, but suddenly they start developing hypercalcemia where the one of the glands becomes autonomous, becomes like an adenoma. So such patients need to also will be benefited with exploration, but here we have to be very, very careful in deciding which is an adenoma and which gland to retain inside, which gland to auto-transplant, right? So here the challenges are identification of the adenomatous one, and here I think what is preferable is to do total with auto-transplantation. There's something called as neonatal severe hyperparathyroidism. It's because of mutation in the CASR gene, and children are born with severe hypocalcemia, but there could be relative hypocalciuria. Here again, total parathyroidectomy with autotransplantation and transcervical thymectomy is going to be helpful. So this disorder could be fatal to the neonates because of the cardiac arrhythmias that are possible and various other complications, and this needs emergency surgery. So to summarize, a biochemical diagnosis is very, very important, and there should be a deep understanding of possible anatomical normal, abnormal, congenital, acquired ectopias, and the troubleshooting protocol. You have to have a clear plan in your mind, and a surgeon should be able to understand and perform the imaging, especially ultrasound on her own or his own, and please correlate along with the various other parameters, and keep in mind the genetics. And it's not a one-man show. You have to be able to work in coordination with the endocrinologist, nuclear physician, and they are your friends. So you have to have very good relation with them. And the treatment has to be tailor-made for each patient based on the disease profile of these individuals. Thank you. So with that, I end my talk, and I'll be really happy to answer any questions that you have.
That was a very good extensive lecture covering all aspects of hyperparathyroidism. Oh, it's an excellent lecture. So before I open this for discussion, so let me tell you two things. First, we have our senior professor, Professor Robinson Smile. So I would like to convey my regards and respect to him. So I'd like to ask him to unmute himself and ask any questions or comments he can do. And secondly, we have Dr. Balamurugan, who is additional professor in our department. So who does a lot of parathyroid surgery. So I would like to ask him the relevant questions and interact with Dr. Ramya and try to bring out the relevant things to all the participants. So over to Professor Robinson Smile, sir.
Good afternoon, sir.
Good afternoon. Thank you, Vishnu. It was a very nice talk by Dr. Ramya.
Thank you, sir.
But I think when you were in Jipmar, I left by that time.
Right.
Yes, sir.
Yeah.
I was in 2012 to 15. You were our medal examiner, sir.
Yeah, correct. I remember that. No, I have actually no experience with parathyroid except that I see them while doing the thyroidectomy
Yes.
and accidentally I have removed them. Otherwise, I have no experience. One thing I know is it is very important to localize preoperatively
Yes, sir.
and also during surgery. Sometimes it's very difficult to find out that.
Yes, sir.
But I'm sure people who are doing parathyroidectomy will definitely be benefited by your talk. It was so nice. Thank you.
Thank you, sir. Dr. Balamurugan. After that, people can unmute and ask question Ramya directly. You have to unmute yourself, which is allowed.
It's a good, very good exhaustive lecture, Dr. Ramya. Am I
Thank you,
audible?
sir. Yes, sir, you're audible.
Yeah. I have a couple of questions. Maybe I think you a little bit you touched upon, maybe for the benefit of postgraduates and for all of us. How do you differentiate between a normocalcemic primary hyperparathyroidism and a secondary hyperparathyroidism?
So, these two are actually clearly different entities, sir. So in secondary hyperparathyroidism, if you're talking about renal cause, so there are many causes for secondary. The most common are two. One is vitamin deficiency, and the other is CKD. So in chronic kidney disease, we know that the patient has renal disease and the creatinine is higher, and there is vitamin deficiency. There could be the calcium is less usually, and the PTH is high, and phosphorus is high because of the renal disease. This is biochemical. And in normocalcemic PHPT, there is increased PTH and the creatinine is normal and the calcium is normal right now. So ionized as well as total calcium, corrected calcium for the albumin. So there is no secondary causes. All secondary causes are ruled out. That's the basic tenet to diagnose normocalcemic. And these patients are going to have probably the other systemic manifestations like low BMD and maybe renal stones or something like that, depending on the patient profile.
Yeah. So one thing you are telling about is they'll have a creatinine problem, but suppose if the creatinine clearance is less, like which is one of the indication for surgery. So suppose in a normocalcemic, yeah.
You're talking about asymptomatic PHPT, sir?
Yeah, asymptomatic PHPD, especially with calcium levels more tending to be normal, where you have a creatinine clearance at a lower level. So how do you really differentiate this CKD associated or?
You mean early CKD versus normocalcemic PHPT?
Yeah.
I think usually we have this. I think our nephrologist can help us because in SHPT the calcium is going to be on the lower side, and in normocalcemic PTH is high and calcium is going to be normal. So creatinine, if it is less, I think we don't categorize this under normocalcemic actually. So any slight hint of renal disease, this actually goes into early renal disease and probably early SHPT. I think time is only going to answer this particular situation.
Okay. The other one I was just feeling is
yes, sir.
If you have a this DEXA scan, whether do you do this bone mineral density as a routine part of workup or
yes,
only
sir. In PHPT? In PHP, definitely. Yeah. Actually, in the past in SGPGI, they used to do skeletal survey. to identify all the at-risk areas for fractures, because at that time they used to present with severe disease. But nowadays we do exclusively DEXA scan. We do 3-side DEXA. The routine DEXA scan, that is BMD, that is done is for 2 sides, that is hip and spine, because this is for screening, especially in postmenopausal women and elderly men, to assess the bone weakness. Whereas in primary hyperparathyroidism, the DEXA is going to be 3-side DEXA: the distal radius, the lumbar spine, and the hip. Because the trabecular bone is going to get affected first, and you see at the ultra distal radius that the BMD can be -4, -5. So this is the classical presentation of PHPT, where on DEXA the ultra distal radius is going to be more osteoporotic than the hip and spine. So here, whenever we write a prescription for BMD for these patients, we always write 3-side DEXA within brackets we write ultra distal radius, hip, and lumbar spine. We routinely do it, sir, and we reassess this after 2 years. There's no point repeating BMD every year, because the clear criteria are to repeat it after 2 years. So then to see if the bones have improved in their osteoporosis or not.
Yeah, other thing you are telling as secondary causes is vitamin D deficiency.
Yes, sir.
Sometimes we find in primary hyperparathyroidism also vitamin D is deficient. So
Yes, sir.
what is your protocol in such patients? How do you differentiate? How do you wait whether you correct it, or how do you go about such patients?
Sir, I do it on individual basis. If the patient is having just a milder hypercalcemia, somewhere below 11, maybe below 12, I'm comfortable correcting the vitamin D. So we actually start it just before surgery. So in corporate, like our policy is to, I mean, even SGPGI, whenever a patient of PHPT comes, we don't schedule them for surgery. We operate them immediately. Immediately in the sense within a week or so. So we start vitamin D correction in this patient. So if the calcium is not very high, say for example, just above the normal and below 11, we actually give them good vitamin D correction, because this helps in us confirming, number one, whether this mild hypercalcemia is not lab error and is indeed a PHPT. And number two, these patients tend to have lower post-operative hypocalcemia. So I decided on case-to-case basis. So if the calcium is more than 11.5 or 12, I'm not comfortable correcting vitamin D, because anyways, these patients, depending on the BMD, may need IV calcium. So just increasing the calcium by starting to correct vitamin D may not help. So I think that's how we follow, sir.
Yeah, that's one important point, because we also recently had a patient who had a calcium slightly in the higher level, around 10.5, and patient had low vitamin D, and in fact referred from endocrine for surgery. But when we waited, we thought weekly calcium we'll put. By the time 4th or 5th week, our parathermal levels came down. In fact, we asked her to be on follow-up. So that's one important thing here. Another thing I was just thinking is this differentiating. Sometimes you find there is a intraoperative, you find it difficult to identify a parathyroid. You said visual identification sometimes can be misleading. That's true. But sometimes
Yes,
we have, as you say, lymph nodes. Not only lymph nodes, sometimes I personally have trouble even with sometimes thyroid nodules, which are kind of pedunculated nodules, which will sometimes interfere in the thyroid nodule. So yeah, just maybe a comment on that. So thyroid nodule will have surface that what you call that lobulations will be slightly bigger, and parathyroid will be slightly smaller. That sometimes it helps. So visual identification do help. And yeah,
yes, sir.
Second thing, you were yeah.
Yes, sir. Please go on, sir.
Yeah. The other thing is adjuncts. You were telling about ICGs, and apart from frozen and intraoperative, the recent thing which is coming up. Yeah, am I not audible? Hello.
You're audible, sir.
Yeah. The recent thing which is coming up about near infrared. So do you have any experience, or what is the present latest take on near infrared?
Some of my junior colleagues in SGPG are doing projects on near infrared and autofluorescence of parathyroid tissue. So these are probably more helpful in identifying parathyroid glands during thyroid surgery, not so much in identifying abnormal parathyroid adenoma, because the basic tenet is to identify the parathyroid tissue first and then see if it is vascular or not. So near infrared and autofluorescence by Mahadev and Jensen et al. There was an article in 2019 by Mahadev and Jensen et al. From US. They have seen that the parathyroid tissue has autofluorescence, And of course, by using ICG, we can again see the near infrared and the uptake of this dye. But these are mostly helpful in after you have identified certain a tissue, and whether to see if it is parathyroid or not, or if it is vascular or not. But if we are not able to find a gland, this may not actually help us to identify it. But radio guided can help us. So if we have done sesame in the morning, if there is a little bit of amount of sesame retained within the parathyroid gland, doing a gamma probe identification can help. So one of my seniors, Dr. Chitresh, so he did MCH from SGPJ. He's currently associate professor of surgical oncology at AIIMS Bilaspur. So he used to do a lot of these cases in AIIMS. So radio guided is another possibility to identify the glands. So.
And one more thing is that,
yes, sir. I just wanted to, before I forget, I wanted to add that there is a classification for detached thyroid nodules. So grade 1, I can't remember the name offhand, something starts with S. So there are 4 grades. One is the thyroid is, the nodule is connected to the parent thyroid with a bridge of normal thyroid tissue. The grade 2 is, there is a fibrous connection. The grade 3 is slight flimsy connection, and grade 4 is completely detached thyroid nodule. So these are not uncommon, and especially when we are operating for retrosternal goiters, sometimes we can have detached thyroid nodules, which will become difficult for us to deliver from the neck. So one has to be really careful and aware. And these completely detached grade 4 nodules can pose a difficulty in confusion with parathyroids, especially with tubercle of Zucker candle that can detach from the thyroid sometimes.
Yeah, that's true. Yeah, one more question, probably I'll stop with that.
No problem.
Yeah, is this, there is one indication in asymptomatic patients. You were telling a lot of indications for surgery, primary hyperparathyroidism.
Yes.
There was kind of a controversy. So one is about neuropsychiatric or neurocognitive symptoms as an indication to operate on such patients.
Yes,
so
sir.
What's your take on that?
So in asymptomatic, there are no objective criteria for neuropsychiatric, because there is no way that we can prove whether this is because of the PHPT or not. I think if there is, I mean, these may be benefited. There are studies which have said that, but the criteria doesn't, as of now, include neuropsychiatric manifestations, sir. But if we are very sure that this is because of PHPT, then probably the patient will be benefited. But as of now, the criteria are mostly objective, like the bone disease, the renal disease, and objective criteria.
Yeah, I think sometime back, American Society of Endocrine Surgery gave that as an indication as neuropsychiatric or neurocognitive
Okay.
issues as an indication for surgery. I think the recent papers are now saying that that should not be considered as an indication for surgery.
There have been many studies, but the challenge is to actually attribute the these are so subtle. It's difficult to diagnose and attribute it to PHPT in these patients.
So that's
I
what
mean,
they
for
said.
surgeons, I think whenever a patient with PHPT comes to us, we operate. But our endocrinologists are a little skeptical in referring these patients to surgery, I think.
Yeah. So any elderly patient probably with not much of elevated parathormone or calcium, have you been on any conservative management? Have you tried conservative management in such patients, or do you operate on all patients? Like though there are some not much asymptomatic elderly.
I haven't encountered such patients, sir. If the patient is severely comorbid and just having mild disease, maybe cinacalcet will help. We can just give the patient cinacalcet tablet PTH 30 milligrams OD, and see how they are responding. Initially, they may have some GI disturbances, but they will soon settle with it. So mild disease with high comorbid conditions can be managed like that. But the oldest that I've operated is a 90-year-old patient who has kidney disease secondary to PHPT, which was missed for many years, and he had a big adenoma, very big adenoma, and he, I mean, I don't know how much benefit the patient got by it, but calcium definitely normalized, and his BMD, I'm sure, is going to improve. But this patient was otherwise not having any other comorbidities. He had, I think, mild CKD because of the PHPT. So sometimes a PHPT patient can turn into SHPT also because of CKD. So that is where we have to be, the timeline helps in understanding whether what was first.
Yeah, one more question is this multi-gland disease you're always attributing to either familial ones or in the hyperplasia ones. Is there any experience about whether multi-gland disease can be sometimes more than one gland, can be a double adenoma? Do you have experience in that, or what is the percentage of that double adenoma? Not
2%,
multi-gland
sir.
disease.
Actually, this literature says 2%, but I have I've heard of cases, but I have not experienced double adenomas. But they don't tend to have family history or anything. They just coincidentally have 2 adenomas. I think I'll be very careful in ruling out multi-gland disease than believing it to be double adenoma, because it's so rare to begin with. And number 2, we don't want the patient to end up having the same symptoms after we have operated also. So still I would do a bilateral exploration and be sure if the other glands seem normal, probably I'll leave them alone. And these patients have to be counseled very well, because there's so many possibilities. The surgical outcomes can be so many possibilities can be there.
Yeah, as you say, so but I read reports where after excising one of the adenoma, then send the PTH values by your modified criteria, Miami criteria. If the fall is not there below 50%, again explore and they find another adenoma near to that, and then excise again, repeat the sample. If it is less, then they say it's probably a double adenoma instead of a 4-gland exploration. That's what I
No,
read
sir,
the
I think
report.
that's not a standard thing. That's not a
just
standard thing, because it is so rare, and if we just limit ourselves to another adenoma, then we are probably missing other glands. So the incidence of double adenomas is so less that if we are just falsely happy that we have removed 2 abnormal and the PTH fallen, and it may rise again. So maybe that is a dominant gland. So the other abnormal gland will start rising later. So visual identification and being very sure is important, because the PTH dynamics are different. So in patients with CKD, if when we're operating for SHPT also, we can use IOPTH. There the dynamics of the PTH are different. So the drop may not happen very soon. So other thing is the drop may happen now, but it may start rising again if in multi-gland disease, there are some dominant glands and there are some suppressed glands, though they are abnormal. So once this dominant gland is removed, the other gland starts over functioning. So I think visual identification is very important. That's what I think.
I don't have an experience. So yeah, just maybe a comment on thing like one thing which you said, ultrasound, there is a vessel which is entering. I think now the name is polar vessel.
Polar vessel.
Polar vessel. So polar vessel is a differential, what you call a confirmatory thing on ultrasound, as you rightly said. So
polar vessel versus hilar vessel. So in lymph node we have hilar vasculature, and parathyroid surrounding vascularity with a polar vessel entering mostly from the inferior thyroid artery. We can, if we put Doppler, we can see that inferior thyroid artery is coming and the branch is coming into the parathyroid.
The other comment is just you were saying subcapsular ligation at the superior pole vessels of thyroid. So one more thing, added advantage is you avoid injuring your external laryngeal nerve, which also adds to the morbidity of surgery. So that's one more thing you should point.
Yes.
Yeah, thank you.
Thank you, sir. Thank you. I totally do sutureless. I don't like it anything. Just go on the gland, buzz and drop them down. So we don't injure anything. That's the safest possible way to do thyroidectomy for benign. But for malignant, again, you have to go ligate them, of course, close to the glands and identify parathyroids, because you're going to do central compartment dissection, and there it's important to identify everything and keep them intact.
Yeah, that's true. Okay,
thank you, sir.
Anybody else would like to ask? Please unmute yourself and ask. You can wait for 30 seconds. So that was an excellent interaction between Ramya and Balamurugan. And Dr. Ramya, your lecture was an excellent one. I thank you for the same. If there are no other questions,
thank you, sir.
I think we will end the session. Thank you all.
Yes. Thank you, everyone, for making time on a day of India's final.
Thank you.
Have a happy weekend. Thank you, sir. Thank you so much for giving me this opportunity.
Welcome. I'm ending the session now.
Sure.